Hello everyone, and welcome to our neurology review. As you know, the neurology system is associated with our nerves in the periphery, in our arms and legs, and also with our brain and the nerves that come off the brain stem. This neurology lecture will start with the 12 cranial nerves that come out of the brain stem. And each cranial nerve has a function. So 1, the olfactory, is smell. 2, the optic nerve, sight. 3, the oculomotor, which is movement of the eyes, and so on and so forth. You can read this just as easily as I can say it. Now, there are different types of cranial nerves. Some are just sensory, as indicated by the S, and some are just motor, as indicated by the M. And some are both sensory and motor. So I'm afraid that it's good to memorize all the cranial nerves and be familiar with what they do and how you test for these nerves. This chart shows you how to test for each cranial nerve. Now, you should have had this, or maybe you will get this in your physical diagnosis class. So we're not going to go into this as deeply as they might in another class. But I want you to become familiar with this. Now, this is the brain. And I just want to show you the blood vessels associated with the brain. Perhaps you've already dissected your patient and you remember this circle of Willis. You remember the internal carotid that goes up and feeds this anterior part of the brain, and the vertebral basilar, which goes through the cervical spine, and they all communicate. So basically, if you get a clot formation in the internal carotid that goes into the brain, you've had a stroke. So this picture just shows you the different parts of the brain and the different arteries that serve each part of the brain. So when I examine a patient and see their neurological deficiencies, I will know where in the brain that problem is developing. Now, I am not going to ask you to memorize this. This is basically an introduction. But I do want to point out, see the slice of the brain? See where the control of the foot is? And this is the anterior cervical artery, which kind of corresponds. So I will point out that if the patient develops foot drop, perhaps you need to look at that area of the brain serviced by the anterior cervical artery here to see if that patient had a stroke or metastasis to that area of the brain. So I do want to point out this aspect of the 7th cranial nerve. So that circle the 7th cranial nerve, I want you to know about that. Now you can have a problem with the 7th cranial nerve in the brain, or you can have a problem in the ear, which is more the peripheral Bell's palsy. Notice the difference of our patient who is on the peripheral and then who's central. The person with the peripheral Bell's palsy, say the inflammation of the nerves in the ear, they lose activity in their whole side. Whereas patients with a stroke or a tumor affecting the 7th cranial nerve, they lose only part of their facial expression, but they preserve their forehead movement and they're able to close their eye. But basically, they have a crooked smile and nasolabial fold depression. So one of the most common things we see in the office is headache. There are many different types of headache, as you can see. You can have primary headaches or secondary headache. a secondary headache is caused by something else. So if I have a brain tumor, then the headache is not just from the brain itself, it's from the neoplasm material that's causing that headache. So which headache is the most common? Can you guess? Well, it's the tension headache, accounting for 40% of all office visits. Now let's look at these various headaches. Sinus headaches, people often get those. They're congested and they have pain in this bluish area. Cluster headaches, their pain is usually around one eye. Tension headache is a band-like squeezing around the head. And a migraine is also usually on one side and usually associated with, say, some nausea and vomiting or some tearing. It's usually always the same type of headache. Now, this chart classifies some of the differences between migraine, cluster, and tension headache. It's good to point out that some people have a migraine headache without aura, and some people have a migraine headache with aura. An aura is a sensation that predicts that the headache is going to come on. Some people get an unusual smell, or they get flashes of light in their eyes, and that would be an aura. So this is a good chart to be familiar with. I do know your test will include some discussion of a patient or two with a headache. Now, characters of headache can vary. Let's look at the migraine headache. I want to point out these qualities: pound, pulsatile quality, onset 4 to 72 hours before they present, unilateral with nausea and vomiting and disabling. And it's good to remember that sometimes there can be the aura, such as flickering of lights or spots in front of your eyes. There may be some neurological symptoms that go away. There are various medical treatments. Some people do well just with aspirin, acetaminophen, nonsteroidal anti-inflammatory drugs. Then we try to get stronger medications if the first medications do not help. Now, people who have chronic medication may use this series of medicines, propranolol, but I've been using more amitriptyline and topiramate. You have not had pharmacology, so we're not going to go into much more detail in these particular medications. Now, an exertional headache is something to think about. As the name suggests, it's a headache after physical activity such as running, coughing, or bowel movement, and I have seen it a few times, patients who come in complaining of a headache after sexual activity. Now, I do an evaluation of these patients. I'll usually do an MRI to make sure they have no lesion, because in a literature review, there was found to be a lesion in 22% of patients. And I will do a cardiac evaluation if they have risk factors for heart disease. A cause of headache associated with fever is meningitis. And the meninges, if you remember, are the coverings of the brain and spinal cord that become infected. Now, risk factors are ear infection, sinus infection, and other infections that enter the blood vessels and go to the brain. These people present with headache, neck pain, photophobia, nausea, vomiting, confusion, seizure, and some exam components called the Kernig and Brzezinski sign. Basically, this means with movement of the extremity, they will get stiffening and tightening of the neck and perhaps even some moving. Now, various bacterial organisms will cause meningitis. Now, you probably all heard of Neisseria meningitis because now we have 2 vaccines for that. But take a look at the others that can cause infection. Viruses can also cause infection, and there's also encephalitis. We're seeing more and more problems with the West Nile virus. When we want to diagnose meningitis, we will do a lumbar puncture. And we notice in the healthy individual, they'll have low white blood cells. and this normal level of glucose and protein. But if you have bacterial meningitis, you have decreased PMNs, which are fighting off the infection. You have increased pressure because of all the activity. You'll have decreased glucose because the bacteria is using that. And you will have increased protein, accounting for the cell wall of all those bacteria. This is basically how a lumbar puncture is done, and see that it's done between the third and fourth vertebrae in the lumbar region because the spinal cord stops at L2. Basically, we want to prevent meningitis. So we give these vaccines in the general population and in people without a spleen, because people without a spleen are unable to fight off the encapsulated organisms. So we give the Haemophilus influenza type B, the pneumococcal vaccine, and the meningococcal vaccine. I would bet that many of you had the meningococcal vaccine before you started college. Now, the advisory committee does recommend that everybody get the meningitis vaccine. And now there's a new meningitis B vaccine, which they are recommending. This is a vaccine that you take as a series of 3 shots. And the reason for this is because a recent outbreak in Princeton was shown to be from Neisseria meningitis B that was not covered in the original vaccine. Now we're still talking about headaches, trigeminal neuralgia. And that's a recurrent headache, but it has facial pain in the trigeminal area. These people say they have a stabbing or electrical type of pain in the area of the face where the trigeminal nerve is, and then it will spread to the forehead, the cheek, and the chin. Notice facial pain. Temporal arteritis also have some pain in the temporal area, but these people are associated with visual disturbances and pain in the jaw. When you do some blood work, you might get a high SED rate, which is a value that is elevated associated with inflammation. The key thing here is the visual disturbances. It can lead to blindness in 15 to 20% of people. Now this shows the trigeminal ganglion and how they have intense pain here. Notice in temporal arteritis, it's almost pain in the same area. They might have some blurred vision here. A transient ischemic attack is what some people call as a mini stroke, and it's the sudden onset of unilateral paresis, speech disturbance, and transient monocular vision loss. Basically, we want to do a thorough history when a patient comes in. Do a whole exam, especially a neuro exam, and we'll do an MRI and then a CAT scan. We will also do an assessment to see if they have cardiac problems, because some cardiac problems can lead to stroke or TIA. So the best thing to do is prevent future strokes when someone comes in with a transient ischemic attack, because 10 to 20% of people will have another incident within 48 hours or even as long as 90 days. So what we need to do is treat their risk factors of hypertension, smoking, obesity, and inactivity. Give them a statin to decrease their LDL. Give them an antiplatelet agent. Or maybe look at their carotid arteries and see if there's blockage. And if there is, you might want to consider angioplasty or removal of that plaque. So this again wants to emphasize the aspirin, dipyridamole, clopidogrel, but you don't use them both, one or the other. Now, I'm sure you've all heard of atrial fibrillation, which is an irregularity of the heart. These people have a very high risk of developing stroke because of clot formation in the heart that is shot up to the brain in a good squeeze of the heart. Basically, people are now given Coumadin or warfarin, and we follow their PT by looking at the INR. The INR must be maintained between 2 and 3. People without warfarin were found to have a 4.5% chance of stroke, whereas people with warfarin had a 1.4% chance of stroke. But people don't like checking warfarin because they feel that it's hard to adjust and people have to get a lot of blood tests. You have to watch what food that you eat. So as a result, we're using other agents in order to control the clot formation. You've probably seen commercials. These are called the oral anticoagulation agents. And the nice thing about them is that you don't have to monitor their blood work and you don't have to adjust your food. So who needs anticoagulation if I have atrial fibrillation? We look at the scores. There's 2 different charts to use, which is either the CHADS 2 score or the CHADS VAS score. And it lets you know basically who needs to have anticoagulation. All in all, if anybody has a score greater than 1, they should have anticoagulation. Now, a stroke is a permanent cerebral ischemic event. It lasts greater than 24 hours, and the symptoms may last longer depending on the type of stroke, the location, and whether or not they come in time to have intervention. 80 to 87% are ischemic, and 13 to 20% are hemorrhagic, meaning you have a bleed in the head. And this can be intracerebral or subarachnoid. So risk factors are age, family history, obesity, diabetes, high blood pressure, tobacco, AFib, stress, or high alcohol intake. So in the acute treatment, when somebody is coming in with symptoms of a stroke, we might want to consider thrombolytic therapy. And this must be started within 3 hours, and as long as they have no other problems. We want to give them oxygen, especially if their PaO2 is low. Now, if their blood pressure is extreme, then we will lower it. If it's not extreme, we're going to try to maintain cerebral perfusion. For imaging, when someone comes in with suggestion of the stroke, we will do a CAT scan to make sure there's not a bleed, and then we will probably do an MR for a closer look at the brain. In the hemorrhagic stroke, if we're worried about that, again, we're not going to do any contrast. We'll start with a CT scan and then look at the MRI scan. Now, vertigo is another complaint that we get in the neurological patient. Vertigo is the feeling that the room is spinning around you. You can have peripheral vertigo or central vertigo. Peripheral most likely is due to the inner ear or could be due to positional changes. The central is usually the brainstem or cerebellar lesion, meaning like a stroke there. And it can also be associated with positional change. Moving down, let's talk a little bit about seizures, which is a sudden change in neurological activity caused by excessive synchronized discharge of the cortical neurons. Now, you have epilepsy if you have 2 or more seizures that are not precipitated by illness. This chart shows the common causes of seizure by age group. And these are the types of seizures that occur in each age group. Status epilepticus is just the term that we give to situations in which you have 30 minutes of continuous seizure activity. Maybe you've heard of febrile seizures. These occur mostly in children between the ages of 6 months and 5 years. And basically what happens is these children have a fever and then they start having a seizure. Now you want to make sure that they don't have any concomitant infections such as meningitis, at which point the cause of the fever would be the meningitis and not just the fever, or the cause of the seizure would be the meningitis and not just the fever. You may see a lot of patients coming in with Parkinson's disease, and this is caused by dopamine depletion in the substantia nigra of the brain. Basically, what you'll see in these people are several features. Think of the mnemonic trap. They have a resting tremor, rigidity, akinesia or bradykinesia. They're just walking very slowly, and they have postural instability. The other symptoms are a little less prominent. The treatment of Parkinson's disease is displayed on this chart. In essence, we want to give them some treatment that will replace the dopamine in the brain. Some drugs can also deplete the dopamine in the substantia nigra. Fortunately, we do not use many of these medications anymore, but we still see them used in some patients. Now, we talked about the resting tremor in Parkinson's disease. There are several types of other tremors, an essential tremor, which can be autosomal dominant, or an intention tremor, which only occurs when you're pointing at something. Other diseases, myasthenia gravis, another autoimmune disease. This can occur in younger women and older men. So what it is antibodies that bind to the acetylcholine receptors. And these patients present with fatigue, ptosis, which is drooping of the eyelids, diplopia, double vision, dysphagia, difficulty swallowing, and dyspnea, difficulty breathing. The test is the tensilon test, where edrophonium injected into the body will decrease the symptoms. Many of you have heard of Guillain-Barre syndrome, which is an inflammatory neuropathy associated with progressive weakness that is usually symmetrical and ascending. It's another autoimmune disease, and it often follows a viral infection or a shot of the flu, a flu shot or other immunizations. ALS. Everybody remembers the ALS challenge from a few years ago. And this is also a progressive degenerative disease and loss of the central nervous system. This is associated with death of the neurons in the motor cortex. Many people start with a limp. The patient that I saw who started with this had foot drop. These patients have muscle fasciculations for many years prior to developing the disease. We can do an EMG, which will show muscular denervation and motor blocks. Dementia. Alzheimer is the most common that we will see. And basically, we figure this out by doing mini mental status exams and other evaluations that will look at the patient's memory. Alzheimer's disease is due to neurofibrillary tangles and plaques and amyloid deposits into the brain. They have progressive short-term memory loss, depression, confusion, inability to perform complex tasks, and personality changes. There are several medicines that are used. I personally have not been impressed. They don't restore the memory. They just delay the progression. These are a few articles that talk about the cholinesterase inhibitors in Alzheimer's disease. Multiple sclerosis is another disease of the neurological background, and they also believe that this demyelinating disorder is a possible autoimmune disease. Most patients will be diagnosed between the ages of 20 and 40. And the MRI is really the diagnostic tool that shows white matter lesions. Often they will present with some visual changes, such as optic neuritis, where they'll come in and they'll say they have some blurred vision, they just can't focus. and then the exam will reveal these other findings. There is the classic triad: scanning speech or broken speech, incontinence, and problems with horizontal gaze and nystagmus. You can see many of these findings with multiple sclerosis. Now let's talk a little bit about radiculopathy. People have the spinal cord coming through the vertebral column. Here's the cervical area, the lumbar area. Sometimes you can have trauma, which will cause bulging discs, which will be associated with pain down the arms or down the legs. This chart will show you which neurological reflex is associated with which nerve root. I'm assuming you've had this in your physical exam course, but for our purposes, let's remember the patellar and the Achilles. Carpal tunnel is compression of the median nerve at the wrist. Patients complain of wrist pain that comes up their arm. They have a difficulty grasping because of numbness in the thumb, middle, and index finger. And you might see some atrophy in the area of the thumb if it's been going on for long enough. These are the tests used for diagnosis. The Tunnel test, where you try to reproduce the pain by tapping on the nerve, and the Phelan test, where you also try to reproduce the pain. Treatment with wrist splints, nonsteroidals, injections, and sometimes surgical release. So that's the end of our neurological session. Please write to me if you have any questions or save them until next Monday when we're able to discuss them. I thank everyone for observing this. And again, I look forward to any questions. We will start with an activity when I see you again.